So I will get started. Welcome, everybody. My name is Marcella McGuire. I lead CSH's Health and Housing Work nationwide, and really excited to welcome you on here to session 5, documentation and billing. All right, next slide, please. We'll start with who we are, I believe. The next slide. So I introduced myself. Ambrosia, you want to say hello too?
Hey, you guys. If you're new here, you probably don't know who I am. Hopefully, if you're not here, if you're not new, you do know who I am. But just in case, I'm one of the facilitators here for our 1959 Medicaid Academy, senior program manager at CSH, background in clinical practice and in the housing and healthcare system world too. So glad to be part of your transition or maybe your integration if you're not new. Are you ready?
I'm ready. All right, next slide, please.
So who is supposed to be in this session? We mentioned that we absolutely welcome Blue Cross Blue Shield. Looks like we have the state on the line. For our sites, we definitely want to see your program lead so that they are informed about how we're going to do this documentation and billing, right? As well as a fiscal lead, because this is about money, and then our quality leads too. And again, we've talked about the fact that all organizations have different capacity, different sizes. So some of you guys are wearing multiple hats, if not all the hats, and some of you have different folks representing these roles. So however that shakes out, we're glad to have you here. If these people aren't here, we'll send them the link so that they can sign on right now and hear what we have to say today. So for this session, again, I mentioned we're talking about documentation and billing. To accompany that will be a billing guide. I think it's going to be specific to the state process for billing. And we're hoping Blue Cross Blue Shield has some related resources around how you submit through their system of choice, which I think is Availity, right? And so we'll be looking out for that resource shortly. We also have talked about the fact that our role as a TA team is to not necessarily an influence or change maybe the policy requirements. DHS is the one that sets the requirements or the what. Our role is to really facilitate the how, the administrative process to submit and hopefully be compensated, right, to bill Medicaid successfully. We've been hopefully giving you tips and tools, right, opportunities to share across agencies. And if you guys are further along, we absolutely welcome your feedback, whether that's in the chat around your experiences with this, or even, after we debrief when we go out into breakout sessions too. So we hope that this can be a learning collaborative as well for folks at different stages. And then we'll be exploring maybe some individual coaching for agencies who do need additional support, who may be newer to this process or maybe even struggling. So there should be some hopefully opportunity post our academy to engage in an ETA. I think all of you guys at this point, agency-wise, have completed our TA assessment tools, so that has greatly informed us as to where you stand. But absolutely beyond our weekly calls that we've been hosting every Friday from 3 to 4, we absolutely, I think this week is going to be tomorrow because of the holiday, but absolutely come to that, ask the questions. There's no stupid questions, no embarrassing questions. This is a safe place, right? But beyond that, we're hoping to also maybe offer some TA as well in different forms. And we've talked about this too, right? So when we're becoming a Medicaid provider, for those who are new to this, or we're expanding our Medicaid practice, right? So we're looking at this from a different lenses. And these are the 4 lenses that we've been reinforcing throughout our time here in the Academy, which is the programmatic impacts of integrating Medicaid. What's that going to mean for our staffing, for the training that we need to incorporate? What service provisions, what services are we going to be offering or expanding as a result of this? And then strategically from a business planning standpoint, what partnerships, MOUs we need to establish for providers who may complement our services or help make our services happen if we're growing or we're trying to do something new, that we need a partner at the table to make happen. And how do we long-term plan? We've definitely talked about like total cost of care, budgeting, and making sure that we can be sustainable beyond when we're waiting for reimbursement, right? Because this is the reverse process. We do the work and then we get paid. So we need to be strategic around how we sustain our projects and our programs. And then looking at the data, I know session 6 will dig even deeper on our ability to manage that data, not only managing it, we talked about that when it came to like HIPAA and compliance and keeping things safe, but now quality assurance will be session 6. So how do we know we're doing good work? How are we internally evaluating that, externally communicating that, and using best practices? And then just the logistics that everyone has to consider. What happens, what needs to be changed around our HR processes, any legal agreements we have, and the way we, reconcile our budgets and manage financially and plan, again, for that sustainability. Hopefully you've been getting emails from me with the copies of your PowerPoint slides and your respective tools, but long-term, the goal also is that you should be able to rewatch these sessions, and they should be posted on the state website along with copies of our slide decks. Again, we'll have that billing guide, and then we'll just have a template of a service plan for those who may benefit from that, who are newer maybe to that practice, to get an idea of what a good service plan is, because again, we're talking about documentation as well as billing. So those two tools will be shared post-session as well. All right, take it away, Ms. Marcella.
All right. So this is a flashback from session 2, who's eligible for 1915I services. 1, the individual has to be a recipient and enrolled in what's called the traditional Medicaid program in North Dakota, and or they have to be Medicaid expansion. And it's really important. You'll learn today why it's so important that you know whether people are expansion or whether they're traditional Medicaid, because you're sending the bills or sending the claims into different places depending upon that. You can have a household income up to 150% of the federal poverty level, but no higher. You have to have a qualifying behavioral health diagnosis, and the state has an easy to find list of all of those diagnoses. And then you have to have a HUDA score, the World Health Organization's Disability Assessment Scale, score of 25 or higher. Lots of people with disabilities don't need this level of support. Some do. The HUDAS is how the state makes that distinction there, et cetera. So this is the eligibility criteria. So if you're serving people and they meet all of these criteria, you can't have one, you can't have two, you have to have them all. But if you have them all, they could be eligible and could be enrolled in the services. Next slide, please. We're here to talk about billing for. So it's important to know that 1915I were part of a larger program within the state called Home and Community-Based Services, because there are a lot of rules and regulations and requirements the state's going to put in place because they're part of the HCBS program. So these are all of the different services that are included in 1915I. Care coordination is really the bright, it's the door into all of the other services. Everybody receives care coordination, and then they receive an assessment to see what their needs are related to all of these other services. The state is doing the authorization for the services, but the care coordination agencies are doing the recommendations for what the state authorizes there. So the state will be reviewing that. It's really important, as we've talked in a couple of other sessions, to look very closely at the 1915I service descriptions for all of these services that the state has put in place. If you're doing something, if you're doing an activity that fits under the service description, then you're doing a billable activity. And if you're doing a service that doesn't fit under that, maybe it's valuable, maybe it's helpful, but it's not included in the services definition, then you're doing something that's not billable time. Next slide, please. So this is I was thinking about this was the next slide, because we talked about this, I think, in a previous session as well. Whenever your direct services staff, hands-on staff that are working with the individuals, are with the service participant, they're engaging with activities that meets the DHS standards, that is billable time. From a financial perspective, you are trying to maximize billable time in order to build your financially sustainable program. That being said, you have to be doing activities that fit within the service definitions, and they also have to fit within the person-centered plan and your service plan, because it has to be something that's helping the individual reach their goals. We can't do something that's outside of that service plan, that's outside of those goals. That will not be billable time. So it's not just activities that fit under the service definition, it's also that are aligned via what we like to call the golden thread within the service plan, within the person-centered plan here, et cetera. So for time to be billable time, and we'll talk about all of that soon, is that it has to fit within the service definitions. There has to be a clear, I said, I like to call it a golden thread from the care coordinations, develop person-centered plan, your person-centered plan, to your service plan, to the actual activity that's happening. And you have to be able to easily trace them back. And you have to be able to easily, someone who's just looking at the records, can't talk to anybody, because we're here to talk about documentation, just as looking at the records, has to be able to document about how your activities help individuals meet the goals that are part of their person-centered plan. So from a financial point of view, you're trying to maximize billable time. From a compliance point of view, you're trying to make sure you follow everything in the services definitions. And from a best practice point of view, you're trying to give people the services they need that allow them to be successful and integrated into our communities. So again, complicated each of these lenses: best practice lens, fiscally sustainable lens, compliance lens. All of these different lenses you at different times have to take a look at and make sure that your documentation fits with there. Next slide, please. So we also want to talk about what's called a payment structure. So there are about a dozen services within the 1915I services. Most of those services are payable on a payment structure of what's called 15-minute increments. All of the services under 15-minute increments, care coordination, all the way down to housing support, all of those services are billing on 15-minute increments. We'll talk like exactly what 15-minute means in how you define 15 minutes in a minute. It's not as simple as we might have thought. There are two other services that are also what's called a per service. So every time you do this, you do the service, you get paid for that service, regardless of how little or how much time it takes. One is non-emergency medical transportation, getting people from their homes and from the community to doctor's offices, doctor's appointments, procedures, things about that. That's a billable service if your agency chooses to sign up for any what's called NEMT, or non-emergency medical transportation. And finally, community transition service. You've been assigned to work with someone who's in a nursing home, who's in another kind of institution. You're helping them transition back into the community. There is also a per service amount of that. So you're documenting all the work that's done to achieve the goals for the person service plan. You're trying to think as broadly as possible. The fee schedule here is listed. You'll notice that for each of the fee schedules, it says care coordination, 15-minute increments, here's the cost. Housing support, 15-minute increments, here's the cost. And then it says per service for the other two. That's where we get this information from, and the fee schedule down there. If and when DHS would change the rate or change any of the payment structures, that would be going up on the state website, and there'd be a conversation as well. So you're organizing your documentation in order to be able to track exactly how much time you're spending with people doing billable services, because that's the documentation that you're going to need to support the claims that we're going to talk about later. And with that, I believe I hand it back to Ambrosia to start talking about their individual service plans. Next slide.
So I know that we're all at different stages with service planning. Some of you are pretty well experienced on developing service plans, and you know how to do this well, and maybe this is just a refresher, but some people are maybe at a different stage, right? So we're just making sure we're all on the same page on just some best practices on what makes a quality service plan. So we want to make sure that when we're offering services that they're coordinated with other providers, right? So if it's possible, we want to be informed on who the recipient is already engaged with in the community. We don't want to make people repeat their stories. We don't want them to have to potentially go through a re-traumatization, right, of having to tell the story again and justify their need for that service again when they're already having those same conversations with other providers doing similar or maybe even same work. So we do want to make sure we're not overlapping in that we're providing a service that's a gap, that's a need for them, or there's a gap for that individual, even if that's our specialty, right? So if you're already getting this from somewhere else, maybe we don't need to develop a service plan for this and have you go through this whole process with me. And then, you know, I think sometimes what happens is we generate the service plan, we create it because we have to submit it for billing, and then it goes in the file and no one ever looks at it again. So it really should be a living, breathing document. As your client's circumstances change, as their needs change, as eligibility requirements change, and you have to adjust, we really should use this document regularly. We should be taking it out, and it really should be informed by the client, right? So the client's voice is reflected. What are they saying their needs are? We're using that first person-centered language, first person language, and also making sure that it's along with their goals, not our goals, or what we think is best for somebody, right? So they are creating the goals, and they are seeing themselves reflected in that. And so again, we're talking about not just creating it and putting it away, but we're pulling it out and reviewing and documenting progress, as well as any barriers that we're noting. And then that's an opportunity for us to put new goals on there as people are able to check off stuff and make progress, right? So just some best practices on what should be part of a service plan, right? So we have to have the diagnosis, especially because we're billing now, that's just tied directly to their capacity to be reimbursed, right? Your ability to be reimbursed. What problem are we addressing for this person? We're also talking about the needs, their problem, why this goal came about based on the assessment maybe you did for them when they came in-house to your agency. Goals should really be measurable, clear, represent what the client wants, and they should be attainable, right? So we want some small objectives below the big goal. Maybe the big goal is I want to sustain sobriety. That's a big goal. So what are the smaller objectives that can help me reach that goal? Maybe it's being part of regular meetings. Maybe it's having a sponsor, right? So what are some of the things I'm going to be doing every day to achieve that big goal? And how are we linking the client's strengths? So what are some of the things that are going well? Maybe they're great self-advocates. Maybe they're knowledgeable about some of the resources already. And so based on that, you know, we should be highlighting that for the client, right? They need to hear that from us. And it should be reflected in the service plan. We should be talking about not just what's going wrong for them and what needs to get fixed, but what are they doing great at that's going to help them achieve these goals? When are we hoping that we're going to get the goal done, right? So when we think about goals, a lot of you guys know like the SMART model, right? Specific, measurable, attainable, time limited. So what's our timeline? When is this supposed to be for the rest of their life? Or are we hoping in 3 months, 6 months? What's reasonable here? And who's going to be doing what? And so sometimes you'll hopefully see on the a service plan, like the case manager is going to call this place. The client is going to visit that place, right, and give a report back on what happened when they went to that other service provider. And then we need to be very specific on which service we're providing or what intervention we're providing to, again, tie it back to hopefully it being a billable resource for us to submit and be compensated for, right? And then, again, we talked about it's a living, breathing document. So there should not just be when it first is created, but there should be a plan to revisit this. Some folks do this every 30 days. Some agencies may do this every 90 days. And then they'll have a whole year review, right, of what the progress is, what are we updating, what are we removing. And then, again, we want to connect back to what makes this a billable activity that's eligible, right? So we have to make sure that it all connects back to that person-centered plan. What is their eligibility? What was the needs identified from the organization, the care coordinator who created that person-centered plan? And that should be where we are developing these goals. And then our progress notes needs to, again, there should be kind of a chain, right? A golden thread here where our progress notes are reflecting what our goals are, and it makes sense based upon that person-centered plan that we received, or if we're creating and passing by, the provider is going to be following that. So critical documentation, the stuff highlighted here has to be there and be consistent all the time in order for us to be able to submit this and be potentially compensated, right, for billable purposes. We have to have on our documentation page, just name and date of birth, good idea. That can be fixed. The date we provide the service is always going to be changing, right? And then when we started and stopped that intervention, you heard Marcella talk about the fact that a lot of our services are billed in 15-minute increments. So if the duration of the encounter was 45 minutes, you need to indicate that on the note. Who is the person providing the service? You know that based on the requirements, certain folks with credentials that need to be there, it's very critical that we know that the person providing it is appropriate for that. So that you have to list who's providing it. And then the plan of care, we want to reference that. Please sign and date it, right? So this is now a document that we're going to be submitting for billing purposes. So the signature and date of the person providing the service has to occur. Some folks, if you're using an EHR, they have like a means to do like electronic signature. If you're doing this a different way, that may mean printing out and signing the note physically in order to upload it and submit for reimbursement. The service authorization number should be on there, and that can be consistent depending on how many increments that person's approved for. And then you're going to have information on claims, your billing, and where you are with the status of the Medicaid payment amounts received. Other things that you need to keep in mind too to have are just a copy of the invoices. If there's anything that you're being reimbursed for, like the transportation, right? So you need to keep a copy of that invoice so that you can provide that as needed. Any other data that's important related to their medical or financial care, like their appointment schedules, any, all your account receivable ledgers, any other financial information that you are collecting that affects your reimbursement, you want to make sure you're keeping this data. And linked below, we do have DHS's requirements on that. Signature policy. Again, I talked about some EHRs may allow for the capacity to electronically sign, right? But we do have to make sure that it is signed by the individual providing the service. Has to be legible, as you can see, promptly completed, has to be dated and timed, and it has to be authenticated. So again, we have, this is overall CMS policy on signature requirement. So again, it's important to know here that billable progress note, again, it can be electronic, but you have to have the date of entry, the date of service, the start and end times, and it has to be in minutes. The location or type of contact, was this community-based, was this a home visit, was this in your office if you have an office, the client name and ID, and then the service name and description. And then you want to talk about the outcome of that intervention. So sometimes you may design this like a SOAP note, right? The subjective would be like what your intention was, what you observed, and what the intention was. The objective is like what happened. And then you're going to capture the action and then the next step, right? So make sure you're capturing all of that, what the progress is, any changes. Again, name, signature, and title of the service provider, and then making sure that the service is relevant to the service plan. It's linked back to your service plan. It makes sense according to your person-centered plan and what was outlined as a need. So it all has to tie back. It can't be something that we're thinking is a great idea. It has to be directly attributed to what we planned out based upon that person-centered plan and then related to the goals in the service plan. So writing your progress road narrative. So you want to, again, focus on the service-related goals. And then making sure, again, it ties again to that service plan goal. I always say it's a great idea to quote the client directly. Don't say he said that he's not going to go do this test that we need him to do. Just, I would say that sometimes we're getting nervous about the language and if it's appropriate, but direct client quotes help to maintain objectivity, right? And hopefully break down the risk of like the telephone effect, right? He said this, I think that's what he meant by that. We don't want to really be interpreters. We just want to put what their words were and make that very clear for them. Very clear for the reader that that's their response to our intervention as opposed to what we interpret they meant by it, right? So we want to be objective as possible there. So again, it says focus on the facts. What happened? We don't want to put our opinions in. We don't want to have subjective information or try to interpret what people meant to say or what they meant to intend with what they said or did. And you want to make sure that when we're documenting that it makes sense that the time spent on the activity was appropriate. So if you're only spending 8 minutes and you're trying to come up with a plan for them to be housed, right? If you're doing housing supports, and if it's not just like a phone call, right? You're saying that you are helping them search for housing and you did that in 8 minutes, that might not make sense. And also maybe the reverse, if it takes 3 hours to have a conversation on the phone about something, that might not make sense either. So it needs to be a sufficient duration, I think, both ways. And again, we talked about including clients' responses, where they are with the progress related to the goal we set, and what's our plan for next steps. So if you're writing like a SOAP note, for example, that would be the P for plan. We talked again about justifying the time spent. So I think sometimes people get nervous after that conversation for that total cost of care, making sure they're hitting productivity amounts and making sure that they're going to generate the revenue they need to justify doing this work, right? But we don't want to get caught up too much in that cycle because that can lead us to maybe make a decision that is poorly reflecting on us at a later point when we have an audit. So that is definitely something of concern when folks start getting into the Medicaid world. They're thinking, well, if I have a group, I can maybe bill 45 minutes for everybody here instead of maybe per se billing it as a group activity. Folks just get so nervous about getting compensated. I think they get down a rabbit hole, and there's a slippery slope to making mistakes that make us lose money and have money pulled back from us. So we really just want to make sure that we're documenting accurately, and that what we did is what we said we did, and that we're not getting too caught up in trying to stretch something to make it billable. I know Marcella talked about like that 15-minute increment and how do we measure that, and this references like the 8 minutes, and she'll talk more about like 8 minutes is that minimum that might allow us to fall over into billable time, but we don't want to stretch stuff to make it happen just so that we can build something, right? We want to be ethical, and we want to do the right things and not get caught into a situation that actually might cost us more money later by doing things the wrong way. We also talked about this last week, but I think it's important to reinforce that, you know, the training is critical to making sure that the notes reflect the work that we're doing that makes sense, right? So we were creating a service plan. The goals should make sense based upon what we know by evidence-based practice. The notes or the intervention we provide definitely should be tied to evidence-based practices. So that means your staff need to be trained on how to do the work well with the client, right? So making sure that we have a trauma-informed process. And what does that mean? Really, that means understanding that the way we speak to people, the words that we use, the words that we don't use sometimes can be traumatizing to folks who are already going through multiple traumas. And so we want to be informed about just the fact that folks are coming to us sometimes as a traumatic event, unfortunately, and how do we mitigate that by the way that we approach them and the language that we use or maybe don't use. And so that starts at the front door, maybe even before they come to the actual service provider when they're calling or when they're coming in and checking in for their appointment. How are they being addressed? What are they being told about themselves in that first encounter or subsequent encounter? So we just have to make sure that everyone's on the same page culturally around making sure that it's safe for the clients to engage with us and that we're person-centered in the way that we approach our work. Making sure that we have technical training around compliance. We talked about the important elements that need to be there in our service plan, the important elements that needed to be in the billable note. And so if there's content missing, that affects your ability to be reimbursed, right? If the diagnosis isn't listed, that may affect your ability to be reimbursed. If someone didn't sign their notes, may not be able to be reimbursed. So that technical training around compliance is critical. We need to learn about harm reduction, cultural competency, or humility, which, believe it or not, are different, and thinking about what it means to be anti-racist. Because again, we know the folks that are coming to us are already going through a traumatic event, sometimes just by engaging with us. And then beyond that, they're already vulnerable by other systemic issues that have brought them to be in the space to need our help. And so that's important for us to remember, even though we're doing this work with well-intentioned, sometimes things happen without us realizing what we've done based upon what we've learned too. And so getting training around that, or even the folks we're hiring who may be newer, maybe good do-gooders, but maybe not informed around like best practice. Motivational interviewing skills, housing first if we're doing housing supports work. And then we've talked about mandatory and annual trainings on different topics last week as well. But just a reminder again, we're going to make sure that folks are well trained to do the work well when they're creating these plans, when they're providing the actual service, and that our system is set up to not further affect folks and harm them if we can control that while we're creating this work. So some examples of maybe being more objective with your writing, right? We want to focus on the facts. So subjective comment that we might write in a note may be the apartment was a mess. And who defines that? What's messy, right? To us may be different. You might even look at, if you have siblings and even as adults, the way you keep your home may be different from maybe someone else that you know. And so that pretty is, it's objective. Maybe we want to just write what we saw here, which is, hey, we saw food, garbage, maybe clothing and papers blocking the wallways and vents. We're just going to say what we saw. Client was out of control and was kicked out of the store. What really is what happened here? So that they are experiencing some active paranoia and persecutory thoughts, right? That ties right back into their diagnosis, because these are some of the symptoms maybe from a diagnosis where someone's having a psychotic disorder. What did they do? They began to scream at other shoppers, and security called them and escorted them out. client is doing much better living indoors. This is specific to housing supports. What does that mean? How do we know someone's doing better? We're going to say maybe the client was calm, they're confident in good health. They're showing us that they're taking their medications. They have a weekly pill box to track that. When I asked them if they like their unit, how are they liking it? They said, I like this place. I can't stop smiling. I love having the AC unit. So that's like a plus for being indoors as opposed to being outdoors now, right? So they're adjusting well. That's reflected from their own words and what we observed in that encounter. For this one, it could be our assessment that's evaluating their ability to manage diabetes in this example, right? So your person-centered plan is going to include the goal of improving their health. That's the overall big goal. And then we're going to be specific to diabetes, and then maybe beyond the goal are some of the objectives that we're going to see. So this is going to be what the assessment says. They had no food when they came over. He said he asked his neighbors for food, and then they're getting complaints from the property management as a result because he's knocking on doors and asking for food. So now, what is my intervention? So I accompanied him to the grocery store. I showed several important items, obviously would be appropriate to his diagnosis and managing his carbohydrate intake and his glucose, right? And buying healthy food related to what? Diabetes. So this is a diagnosis. It ties directly into why they're coming to us. Then we talked about how to alert support staff if we need food, right? So this is a plan. What do we do when we need food? We tell our support staff. We don't knock on our neighbors' doors. And the next, we also give some resources that talk about how to create healthy meals and maybe information on diabetes. This one is related to peer support services. So maybe your the person-centered plan care goal, which was developed by the care coordinator, you're getting the plan now, says, I like to make friends who support my recovery. This is the client's words, right? This is what they need. So the service plan that you may be developing, the objectives are based on what the client told us they would like to do, right? They said, I want to be involved in my local church. Maybe I can volunteer and help others get the help they need. So I'm becoming a support, and it helps to support my recovery. And they're doing this with their peer support specialist, right? So we're seeing the I here, we're seeing the client's words being reflected in the plan, not peer support directed client to find a church of their choosing to attend. We like the I's, and we like seeing the client's name. And then now if we're writing a note, this is how we would maybe document how we would be fulfilling these objectives. So we're meeting with Joe, we discussed his religious and spiritual beliefs. This is a peer support worker, research local faith communities. Writer acknowledged how important it is to get feedback and information from him on what's important to him, right? This is person-centered work. And now we're making a date, this is our plan, to attend an open house at the Church of Joe's choosing. And now this is our assessment of what happened. We're capturing observations. We're not saying our opinion about it, right? But we're just sharing he was very anxious about attending the open house. We're going to plan is to meet Monday on September 27th. We're going to go to the open house together. We're going to meet prior to attending to discuss his feelings. So this also ties maybe to a diagnosis if he has an anxiety disorder. How are we going to cope with that? And we're going to plan for the event to help reduce maybe those anxious feelings and ability to follow through with this activity. And now what's the result of that? He's feeling optimistic and positive about the process. This is another example. This might be related to housing support for those who are doing this work. So the person-centered plan of care goal, which is developed by a care coordinator. If you're not the care coordinator agency, the client may say, I don't want to be evicted. I want to stay in my apartment. And I also want to learn to get along with my neighbors. And maybe the recommendation or goal is that the client needs housing support services, right? So this is why they're getting the care coordination plan, and you're receiving this as an agency providing that to prevent eviction, because in the past they've had issues with getting along with neighbors. So your objectives will be, as a peer support in the housing support role, would be engaging them in anger management interventions. And maybe another goal they set also is, I want to find some things to do with my time so I don't get distracted and get caught up in talking to neighbors the way maybe I shouldn't. I got other things I can do. Progress note that we would write here. We're going to meet with her to discuss her housing issues in the past, the potential eviction that's maybe looming here. Writer offered a non-judgmental approach, which allowed her to be open and honest. We discussed strategies to better resolve conflicts so that she doesn't get evicted. She agreed to attend the anger management session. So she's going to follow up with our suggestion. This is the plan here. And then also we're going to meet twice weekly for 3 weeks and then weekly after to see how she stabilizes and is able to prevent this eviction. And then what is her response to your, right? We talked about the response and the progress. She's hopeful about this plan and wanting to keep her housing. Any questions, any comments, any concerns? So just some examples of maybe, and we're going to provide this to you guys too. Some of you guys, again, may have been doing this work already, have done service plans for other reasons, and are just maybe incorporating these new services into your agency. So you have a great template to use. But some organizations may want a template. So this is maybe just a good resource for you guys to use that captures the objective, what intervention, and we talked about person responsible. So you would say the client is going to follow up with this. I'm going to call this agency to see if they offer, food pantry services still, because we also know sometimes our resources are old. How often will this be happening? Frequency, because we talked about objectives needing to meet the SMART model with their specific, measurable, attainable, and their time limited. And so what's the goal date here? You could also amend your existing plan to have like your review, like what the progress is. So there's a space where you can create that on the template. If not, sometimes folks just have a whole different document like this one where it just has like the section for the progress and just writing it through. So some folks keep it all on one document and then they just amend it and make the progress note and the dates on the same one. Some create a whole different document where they're just keeping progress towards the original plan separate. And so you could choose to do it this way, and you can see this has a lot less data on it as a result. And then of course, new goals, right? People actually, we would hope, make progress and achieve things. And so because of that, we're now adding new goals and a reason why. And you can see here, it says desired results in client words, their strengths and abilities, how they're going to meet these goals. So we're going to have a strength-based approach and think about the things that are going well for them that will help them to achieve this. So we know in this new age, and now it's been over 2 years, a lot of us have shifted to partial or even entirely remote-based service delivery, right? So the question someone maybe have is, how does that come into play specific to 1915I services? So it's important to know that no more than 25% of our services can be provided remotely in a calendar month. It includes the telephone and secure video conferencing too. Oops, sorry guys. For respite and non-medical transportation, obviously that can't be remote. I think that's a kind of a given why it's not physically possible. For documentation, it's important to know that they have to have choice in whether or not their service is delivered remotely, right? So that has to be referenced or reflected in the documentation that they elected this. And it didn't block their access to their community or affect their ability to engage in in-person services. Also has to be a HIPAA compliant platform. We can't at CSH give you specific endorsement of which ones to use. We'd say, if anyone has any that they'd like to suggest, you can drop those in the chat here. Also, there's now with that, what has happened, there's a lot of information, even if doing a quick Google search around Google search around what's available, you'll know if there's a HIPAA compliant platform. Some folks have even used like health Zoom with the BAA, and depending on your resources and the funding, it depends on what you can use. Oh, so it looks like Monica said they're going to be using Thera. Oh, nice. And you guys will all get an account for providers. Even better, you don't have to research and find it yourself. I think that's awesome.
Monica, is there a timeline for when that will be in place for agencies? I figure agencies, if it's going to be next week, that's awesome. If it's going to be 2 years, they might have to think of an interim plan. What's the timeline here?
It's already in place for care coordinators, and I would say within the next 3 months, we'll have it in place for the other providers as well.
That's awesome. That's awesome. Great news. Thank you for making that happen.
Is there a additional costs associated with them accessing that, or is that included as being a provider?
No, that's just the state is paying paying for the provider accounts. It's the same with like the DD system. The state pays for all of the agencies' accounts and therapy as well.
But obviously, if we can do so, best practice is to provide services directly, right? When it, you want to follow guidance around how to be safe with that, but we want to do best practices to do that as much as possible in a safe way. And as you can see noted here, there's separate policies for each service. So depending on the service that you'll be offering, you want to make sure you use this link to explore what the state website says is a policy for your particular service or services. I think it is, Marcella.
So this is another concept of services, and this is called indirect service. Indirect services, when I am doing something that is supporting an individual, but I am not actually doing it with them. They're not really here. So I am the peer support for Ambrosia, and I'm getting information on what are all the different AANA meetings in my community, but she's not really a part of that. I'm doing the legwork to do that. That could be considered an indirect service because I'm doing it for her. I know why. It's part of her goal plan and a part of her service plan, but it's not part of that, but she's not a part of that process. Indirect service is not allowable except for the folks who are offering care coordination services. So I gave a great example in peer support, but that's not actually billable time. If care coordinators they're talking to family members, they're gathering more information about a person's level of functioning so they can write a more accurate and effective person-centered plan. Care coordinators can, for a limited amount, bill for indirect services. None of the other services are allowed to. And that means the person is not the person is not present either indirectly or via technology. So if somebody's on FaceTime, you're having a conversation, that's all under remote services, as Ambrosia just talked to. Indirect also used to call them collateral contacts, meaning I'm helping, but they're not there, they're not part of that. So it's important to know that unless you're doing care coordination and unless you're billing under care coordination, indirect services is not allowed. So with that, next slide, I believe we go to a breakout rooms. Slide's going to come up, but I'm going to remember. Questions. Okay, good. Any other questions, folks? We, I believe, are headed to breakout rooms for folks to look at what do you currently do for documentation, how do you train it, and what do you want to add to your work plan, given what you're thinking about now after the discussion we've just had, the materials we just shared around service planning and documentation. What needs to be added, what needs to be revised. So I would say we would come back at 1 o'clock Central. That's in about 13 minutes from now, according to the clock on my calculator. And then all right, welcome. Thanks and welcome back, everybody. Would love to hear from people to put in the chat or come off of mute and tell us, what did you talk about? What did you add to your work plan? How does this information help you engage and build towards a work plan that'll get you billing for documenting for 1959 services? Thanks, Monica. If anybody's talking, you're on mute. Is that just me being hopeful that someone's talking?
Chatting's allowed to. If you have to type it, we'll take it. Or you guys are writing the right notes. You know how to have the format down to get reimbursed, so we don't have to worry about it. You guys are just socializing.
All right. We've got a lot of material, so we're actually not going to have a break in this session. I think that's our next slide, but we're going to go past that because we want to get straight to the documentation slide. So next slide, or actually 2 slides. So maybe we'll get you out of here. There we go. Okay, billing. So that's what we're here to talk about. Oh, I will also say that I think you heard us note that Kimberly Behrens is here from Blue Cross Blue Shield, we're going to have some really detailed slides and materials, and you'll be able to reference this for the traditional Medicaid. And Kimberly, I don't know if you've been able to get off mute, or if you can put any information in the chat if you're not, enable to training. Enable to the training that you offer in regard to the billing process, because what we have here is all for the traditional Medicaid population. Oh, Doreen tells us we're entering notes into another program provided by the state called Provider Connect, and wondering how Thera will work with that entry. Ambrosia, we should definitely, unless Jennifer, if Jennifer also is on, if you know the answer to that question would be great. If you don't, Ambrosia, let's put that on our list of questions that we need to be asked. Okay, so the first question everybody wants to know is what are called reimbursement rates, otherwise known as how do I get paid, how much do I get paid? Remember, we talked about 15-minute increments versus per service. This is the rate schedule. I think the last slide actually had the link to where we got this from the state. You will also note that there are codes, what are called procedure codes, H2015 for care coordination, T5999 for community transition services. There are also modifiers, UK for training and support, for family peer support, etc. All of those codes and modifiers are things you're definitely going to need to bookmark this slide for whoever's doing your billing, because that's going to be needed on all of your billing forms. So next slide, please. So most of the services we're talking about among the 1915 IRAs, we say billing for 15-minute increments. And when do we ever spend exactly 15 minutes doing something? So the question becomes, when can I bill 1 unit of service? If I bill for 1 15-minute increment, oh, yeah, I took my camera. That's 1 unit of service. That is a 15-minute increment, and I can bill and I will be paid at the rates if I submit a clean claim and all the other stars are aligned, etc. You'll be paid for that. You have your authorization number, the person's enrolled on that day, all of those things. When you bill for 1 unit of service, when you see a person from anywhere from 1 minute to 22 minutes, you're going to spend more than a couple of minutes with people. Primarily, you're going to be looking at 8 minutes and above, because 8 minutes seems to be when it shifts into the other. So I say 15 minutes because 1 times 15 minutes plus another 7 minutes, that gets you to 21 minutes. If you spent 21 minutes with somebody, you're billing for 1 unit of service. When you get to 22 minutes. When you get to 23 minutes, you are now officially billing for 2 units of service. You've got a full 15 minutes, you've got another 8 minutes added, etc. That is now 2 units of service, and you are billing at the rate determined for that quote 15-minute increment. So I think this slide is another thing people like to put aside and track, etc. So 22 minutes, 7 minutes, 15 minutes plus the 7. And then you see, and you can just imagine the math as you go forward, spending more time with people, etc. So track this. This is going to be something that's going to help you, because on your claims, you're going to have to say, I spent from 2:06 in the afternoon until 2:45 in the afternoon. How many with somebody doing a direct billable service? How many units of service is that? Because that's what you put on your claim. You say that is 3 units of service. I'm billing for 3 right now, and you calculate the numbers that way. So next slide, please. Really important as you think about units of service. So there are, all of the different services have service limits, meaning you can't just bill for 24/7, 365 for a service. We're going to give you the example of housing support, which we know best, but know that each of the different services have this. And there's a link down below to DHS's service codes, rates, and limits. This is where you get this information. All of the services have, except for the per service funding. So if we're not talking about NEMT, or we're not talking about community transition services, they're for every time you do it, get this. But for billing for 15-minute increments, you have to know what's the limits. So 1, you can't bill more for housing supports, our example. You can't bill for more than 8 hour a day or 32 15-minute increments. 32 is just 8 times 5. 32 is just 8 times 4, 4 15-minute increments in an hour. Pre-tenancy supports are authorized for 3 months at a time. If you start on September 1st, you're going to be in service September, October, November. So around December 1st, if you're still doing pre-tenancy, hopefully or not, hopefully people got in service, you then have gotten housing, then you're in pre-tenancy there. But you can only get that authorization for 3 months at a time. Over that 3-month period, you can bill a maximum of 78 hours in that time period. You can be reauthorized. You can ask the state for more than this, et cetera, but you have to have a justification. Why do you need it? Why is a person still in this phase? Why haven't they moved into housing, et cetera? You cannot exceed 156 hours per calendar year for services. Tenancy supports, which is another subcategory under that, is authorized for 6 months at a time. That's 78 hours over a 6-month period. So you can't bill for more than 78 or 78 times 4 units of service. You can be reauthorized at that time, and you can exceed 156 hours per calendar year. Care coordinators in particular may request additional hours to their service limits. The discussion they want to have is, why do you need this extra time? In order to prevent institutionalization, to prevent hospitalization, or prevent an out-of-home or community placement. So next slide, please. So there are 2 ways to submit claims. If you remember, in our second session, I believe, we said that it's really, really important that you know whether your people are traditional Medicaid or whether your people are Blue Cross and Blue Shield, their Medicaid expansion. If your people are traditional Medicaid, you are submitting claims to the MMS web portal, and we're going to go into some real detail exactly what you're doing on there, and you'll have these slides. The Availity web portal is what you'll be using. Kimberly Behrens is here from Blue Cross Blue Shield. I don't know if she's able to get off. She was having trouble getting off mute, but she's here. That's the last I saw in the chat. So Kimberly, I don't know if there's anything else that you can tell us about that. We've got a link to the Availity web portal here, and we definitely will show the level of detail that we're seeing on the MMIS slides. Oh, Kimberly, can you? Kimberly, you're highlighted, but I'm not hearing you. Is anybody else hearing her? She might still be having trouble. Kimberly will definitely be following up with you to make sure we can get similar materials, et cetera, from the Availity web portal for these folks as well. But if anybody sees her, anybody notices her, I might get on, just keep talking here, et cetera. But I really want Kimberly to be able to talk as well, because she's going to have the details you folks need for folks that you're working with who are Medicaid expansion. So next slide, please. Oh, so Availity is what is called, just so folks are getting the lingo down, Availity is Anthem's what's called clearinghouses. The role of the clearinghouse is to pull together all of the information from claims via an electronic hub and to make sure that they're submitted correctly, so that when it actually gets to the MCO knows that everything works, everything is fine, and they are just paying on what they've been giving. The hub works to ensure that they're submitted securely. Everyone has to be HIPAA compliant here, that they're submitted accurately. It's very important that the claims information is including a variety of different pieces of information that are all linked to each other. So the first thing we did in provider enrollment is you got a National Provider Identifier, NPI. Oh, Kimberly says she's going to come back on 9/22 to give a presentation on Availity. Yay, that's great. Thank you. I so appreciate that. You get an NPI. When you get an NPI, then you submit that information to the state in order to get a Medicaid ID number. The state at that point links the NPI with this Medicaid ID number. So you have to put on the claim both the NPI and the Medicaid ID number. If you put on an NPI and a Medicaid ID number that aren't linked by the state, then the state's going to reject that and say something's wrong here, something's not right. Your prior authorization number that you're going to get also from the state that says Marcella is authorized for this time period, 3-month period, 6-month period for services. That's linked to your agency's Medicaid ID number and therefore to an NPI. All of those have to be linked correctly. The addresses for your agencies have to be letter perfect and linked to all of that information. So that's all going to be really, really important in order to do that. Availity is the only clearinghouse that Blue Cross Blue Shield generally uses from what I've seen in work nationwide. But again, I'd want to defer to Kimberly here if there's any other clearinghouses we should be talking about, or if there's another way that submits that information is submitted for your folks, then please listen to Kimberly on that one. So next slide, please. That's the role of the clearinghouses. So billing basics. So at the end of the day, everyone who's submitting under Medicaid or Medicare is using something called a health insurance claim form, or what's called a CMS 1500 form. You are not going to be billing. I'm not going to be billing using paper claims. That's old history, etc. But you are going to have all of the information that's included on the CMS 1500 form. As I said, all of those different pieces of information are going to have to be linked. So we're going to take you through some really clear. Yep. Providers can choose a clearinghouse of their own. This is Kimberly of their choice, but that clearinghouse submits all claims through Availity. So that's great. Thank you, Kimberly. I so appreciate that. So yeah, so claims, when you say claims, what it is all of the information in it's on a CMS 1500 claim form. So next slide, please. We're going to take you through that form and help you understand what some things are that aren't really obvious. There's lots of training from the state on this. This is where we got a lot of our materials from. There's the 1915I policy on this. Maybe it's other things you want to bookmark. There's billing and claims training from the state here for policies and procedures. There's also MMIS claim submissions. So these are all things that you could go through. You're going to see we got a lot of our materials from here, but we've got you. You're an audience, so we're gonna talk this through, etc. But know that you've got other resources. You don't have to, and quite honestly, no one expects you to understand everything we're talking about here today. You're gonna have these materials. You're gonna have this reference, and as you begin to do this, you will have that support. Also know that if you are getting an electronic health record or you're using Therap, these things will also be programmed in a way that supports this. So we want you to understand the basics of claims. We want you to understand what all of the information is, because claims can also be denied, meaning, oh, we're not paying that. And then the state or Blue Cross and Blue Shield will come back and say, this is why that didn't pay. These numbers didn't look right. These numbers didn't match up, etc. Always know, this is new for people who are not in the healthcare world, that if claims get denied, and if it's a reason, if it's something you can change, you didn't write something down right, you didn't data enter something right, you can always send it back with it corrected. That's a standard throughout the industry. So next slide, please. So you are going to need to get an account with your agency under North Dakota's Medicaid Management Information System web portal. You cannot do this until your provider enrollment is complete. Until you have a Medicaid ID number from the state, you can't sign into this portal. But once you get that, then you can go into the web portal and then you can create an account. That's going to be really important here. And Monica's given us some of these screenshots, etc. You see it's Monica's user ID we're sneaking into. So one, you have to have a service authorization. This is also commonly called a prior authorization. Providers must be pre-approved to apply the services. You can do great services, but you're not authorized today under this prior authorization process to do the services. The state or Blue Cross can't pay you for doing the services. The care coordination. So if you're a care coordination agency, this is what you're going to be doing. If you're not a care coordination agency, you're getting referrals from care coordination agencies, know what their part of the process is. Care coordination submits a service authorization for care coordination services. They submit it to the state to allow them to work with the individual on the development of the person-centered plan. And that person-centered plan will give them and help them figure out the assessment, and person-centered plan will help them figure out what 1915I services. So they submit the service authorization to the state approves that, they begin to do the assessment of the individual, they begin to develop the person-centered plan, they bill on those 15-minute increments under activities that are listed under service definitions. When the person-centered plan is complete or the plan of care is complete, the care coordinator sends a request for the service provider. They are giving the individuals who've been approved for services, these are all the people, you've been approved for these services, you've been approved for peer supports, you've been approved for benefits navigation, and these are who offers those services in your area. They're going to have people choose a provider that way. Draft person-centered plan, assigned release of information, all completed. The service provider, they send that to the service provider. the service provider accepts or declines the request. If you accept the request, that means you're going to take on and start working with that person. If you decline the request for capacity reasons, for other reasons, etc., you're going to have to note that as well. If they submit, then you as an agency submit your own service authorizations. So you also have to request the state to say, I do benefits navigation. Kathy was referred to me. Here's the plan of care that says both, here's this person-centered plan that says she's chosen me as a provider, and we're going to work together on this. You also submit that service authorization to the state. You also need to check individual eligibility. And this is where you go into the North Dakota MMIS system. One, you make sure that people are enrolled. Two, you make sure that you see that they've been approved for care coordination. If you're not doing care coordination, remember, care coordination is the door to all of the other services. If you're not doing care coordination, you want to make sure that they've been approved by that agency. If you're checking on someone's traditional Medicaid, you can call what's called the AVRS line at the phone number listed here, and there's info also on how to use the AVRS line. Looks like Kathy's putting in the chat. What was I going to say? Kathy's putting in the chat about availability. That you'll need to call the program, and she's put that number in here. I hope that's going to be those numbers in here, and all this will be explained on the presentation on the 22nd. I have a Jared Ferguson who's saying that for expansion, you must have your Blue Cross Blue Shield contract amended to reflect that you are accepting expansion. Jared, do you want to come off mute and tell us who you are and where you're from, and help us understand what you're saying there?
Can you hear me okay?
Yeah, you sound great.
Okay. I'm the expansion administrator for the state.
And
I threw that in there because there's been some confusion where there's been, okay, we're registered with the state.
Yeah.
We're on fee-for-service traditional Medicaid,
mm-hmm.
but they're forgetting the step of amending their Blue Cross contract to reflect that they're accepting expansion.
Okay. Okay.
And it's a pretty straightforward step. If I remember correctly, they'll email a PDF that gets signed and it gets emailed back to Blue Cross, and then they notify us and we activate expansion on the state side.
That's great. Is there a link to anything on your website that explains this to people that you could maybe drop in the chat?
I'll have to look for it. Usually it's coming from Blue Cross.
Okay.
So Kimberly would be the one that will.
Got it. Okay.
It should have it.
Okay.
But I just wanted to throw it out there that if you're going to be accepting expansion, just there's that extra step in the process to get in, and that's making sure you've amended your Blue Cross contract.
No, that's important. And what if people don't have any contracts with Blue Cross yet?
Then it would be working with provider enrollment on Blue Cross to get a contract established.
Yeah. So if agencies are billing for expansion population, they're required to have a contract with Blue Cross. Is that correct? A correct statement?
Correct.
Okay. So if you're working with anyone who's expansion, you're going to need to have a contract with Blue Cross. Yep. Thanks, everybody. Thanks for getting that. And Jared, thanks for clarifying that. We really appreciate that.
Well, not the first time it's come up, so you're welcome. Try and get ahead of it and save some headaches later on down the road.
Exactly. It also sounds like having a contract is something that you need to have before you can bill. So I may have someone who's expansion, they may be approved, I'm approved as a provider, they have a prior authorization, but if I don't have the contract in place with Blue Cross, that could also get in the way of payment as well. Now, what I don't know is whether it will delay payment or
right now the system is set up to automatically deny if on the state side, if that comes through.
Got it. Okay. So definitely, again, thank you for that, because it's just utterly critical. All right. So your billing steps are also, you ensure that required documentation is completed. Somebody could come back and say, here's the claim you submitted. I want to see the documentation that supports the claim. That's called an audit process. But you need that documentation to support your claim. You submit the claim in the MMIS portal or in Availity or another clearinghouse, and we're going to talk a lot more about the MMIS portal. Then again, if your claim is denied, you can appeal that claim as well. There are some denials that happen and there's nothing you can do about it. If I deliver a service and somebody doesn't have a prior authorization and for that service and they're not assigned to me at that time, I can't bill. No matter what I do, no matter what I change, that can't be, I can't fix that. But if it turns out that on my NPI and my Medicaid ID number, I said my office is Office 101, and then it turns out on my claim, I said that it was Suite 101, everything else matched, but those two things didn't match, I can go back, I can change it, I can make sure that it matches everything that I said on the Medicaid ID and on the NPI, and then I could get the claim resubmitted and approved and hopefully paid for. So that is key to billing. Next slide, please. I'm not going to go in detail, but I want you all to have these slides. There may be about, there's 20 or 30 slides here about submitting a claim, how you sign in, username and password. I don't think these are really helpful to have me talk them through. I feel like it's more important to you all to just have them and be able to go through them. But the slide that's up right now, you're logging in as a provider, your user ID and your password. Remember, you'll be getting all of those when you sign into the system. The other something that I just want to highlight is that you will be giving the system an email in order to say, when you need to communicate with me as a provider, use this email. We recommend that you have an email that's like admin@nexuspath.com or billing specialist at solutions, because you don't want it to be a name and because you can only put in one email. And if somebody changes jobs, etc., then you don't have that way into the system anymore, etc. So create another email, create a really simple email that whoever has the role can always be able to access that email. You don't want to be attached to a staff member. So provider login, next slide, please. These are standard. We're getting used to these systems now, I hope. You want to create a claim. You want to create a professional claim. You are not an institution. You are not a dental practice, none of these. You want to create a professional claim. That's what you're here to do, is entering into this system. Next slide, please. Is this a void or a replacement? You tell them this right away. This is basically saying, nope, this is a new claim. You only say yes if you're putting in for a old claim. Next slide, please. So void or replacement, this is you said. So if you've been denied a claim and you're resubmitting, that's when you say yes. It will ask you these other questions. Next slide, please. New professional claim, you need your taxonomy code. We covered those in the taxonomy code you're using all should be in session 1 for provider enrollment. The tax ID, again, has to be the same tax ID you use for your NPI and for your Medicaid number, etc., and or Social Security number if you're doing it as an individual. So next slide, please. These are all the group taxonomy codes for all of the different services, just so you have them at your fingertips when you're doing this. So again, slide deck's going up with the state website, and Ambrosia will be sending out as well. Next slide, please. Group taxonomy codes. All right, you're doing a new professional claim here. Again, all of the information has to match everything that you put in your Medicaid ID, in your NPI, etc. The organization, address, state, and zip code. Next slide, please. Just going to go through these pretty quickly. Pay to address, where do you send the payments to, etc. Next slide, please. That can be different. Is the billing provider also the rendering provider? You were crying no here. Must be the rendering, yes. Rendering provider. No, just required no here. I'll go to the next slide, please. These are the individual taxonomy codes if you are submitting for individual services, just individuals if you're submitting as an individual. So not, Agency A, not Sanford, not Native Inc., not Nexus Path, but I'm submitting as Marcella McGuire, individual practitioner, then I would use the individual taxonomy codes. I don't think most of you all here are attached to an agency, part of an agency. So you'll be using group codes, but we wanted you to have the individual codes. So next slide, please. So is this the result of a referral? It defaults to no, that's fine. Next slide, please. Member information, you've got to, and this is information that you got from AVRS. You had got to get the individual's Medicaid 9-digit ID number, and then all the basic demographic information. Next slide. Is this claim accident related? Should be no. Prior authorization number, service authorization number, that has to be submitted on the claim. Can the billing be transmitted through the transfer file portal? That's Tiffany's question. We're going to have to check in with that and then North Dakota MMIS people and know that the answer to that question could be different both for Availity or any clearinghouse that Blue Cross is using and for MMIS. If you have an electronic record system, if you have an electronic health record, an electronic billing system that can create, make sure I'm answering the right question, Tiffany. If you have an electronic billing system that create what are called 837P for professional files, HIPAA compliant files, then you are able to submit them directly into the system. You don't have to do this individual. So that's can be in place. If you have that system already in place and that's working for you, okay, I'm answering the right question. Okay, so yeah, so that's great. You don't have to know that. You have to know that you have all this information and then it's all collected into your EHR, but you don't have to go through this detail for every claim. Yes, but we want people to understand what's on every claim and what's in the system. So yes, but if you have and are able to purchase an EHR or a billing system that creates all this for you, this gets to be much, much easier. And we are increasingly seeing billing systems that are not asking for a big upfront investment. We're seeing billing systems that are asking for, long-term, a small proportion of your billable revenues, et cetera, and that helps the system pay for itself. So we don't recommend billing systems, but we do recommend that you're able to do them that way. Much, much easier this way. So you have to have your service authorization number. Service authorization number has to be attached to an individual who has been authorized for the service by the state. Next slide, please. Claims note, you have to put in the diagnosis. Diagnosis code is here, remember, because only people with behavioral health diagnoses are eligible for these services. So that's all going to be required. Next slide, please. Claims data, patient account number, that's the Medicaid number versus Medicaid number. Place of service, you see a couple of different services. Where did this happen? Office, home, school, telehealth, homeless shelter. These are common places of service. The list of places of services are all federally mandated, and the link to the code set is there. So if you have another one that comes up, please grab that. Next slide, please. Claims information, release of information code, you're always not assigned, provider chooses not applicable here, client has signed a release, so you have to get a release of information from individuals, basically saying that you can share this information with the state because otherwise you can't bill. That's always, I think, the safest thing for people to have. What you also may note is that you actually can submit this information to the state under HIPAA because you are doing it for care coordination purposes. But just to be safe, it's good to have a release of information and let folks know that you'll be sharing this information with the state in order for payment for services rendered. Next slide, please. Claim information. New service, here's when did the service begin? When did the service end? What is the place of service? What is the procedure code? And I believe we had a slide earlier with all of the procedure codes on it. What's the procedure code descriptor? Are there any modifiers? These are the HCPCS code, HCPS codes, etc. We'll share them with you as well. And then you have for units of service down here, and then you have to calculate what you expect. So if the rate is $10.73 and you are billing for 4 units of service under this claim, etc., you have the procedure codes, you have the descriptors and the modifiers there. You're also doing the math and telling them $10.73 times 4 is, $44, a little less than $44, etc. So you're giving them all of that information. You've got the diagnoses on here, unit codes, and units, etc. Again, don't think you've got to walk through knowing all this. You're going to have this as a reference. And this is all in our billing guide as well. So next slide, please. 15-minute increments. We went through this earlier. So just to remember, you have to bill on the claim how many units of service you are billing for, depending upon how much time you spent with people doing billable services. That's how you figure out how many 15-minute increments or how many units of service you are billing for. If you also see UOS in the billing world, that stands for units of service. So next slide, please. Procedure codes and modifiers. Yes, this is the section you need the code there. So if I'm doing care coordination, back on that slide where it said procedure code, I need to put in H2015 and I'll be paid $20.86 for every 15-minute increment following those rules there. So again, just all for your reference, and then also the state website where you can find all of this information. Next slide, please. Step line, new item. So service date begins, service dates end. This is the same thing again. I just wanted people to say, to know diagnosis, you get prior authorization from the state, you get the unit codes there and the units of service. All of that has to be entered in. Service authorization numbers always start with a W and is a 10-digit number. You can only submit one service authorization number per claim. So per file, you can put in for multiple dates, et cetera, but you all have to be under one service authorization per claim. Next slide, please. Thank goodness for these slides. I wouldn't remember all of these details without the slides. It's just too much. And you have now claims submitted. Print and save for your records. You will get a number of what a number that references the claim. If there's any problem with that claim, you're going to need that number back in the system. So you want to have a way to track that number. Print and save that for your records. The next slide, please. You can check claim status by calling the AVRS line. You will need that number that says, oh, claim 444-666-222. All was in there. You're going to need that number in order to use that into the system. And your MMIS web portal account may also show where claim status is in the process. Thanks for the emoji. Ambrosia. So appeals. Let's talk about appeals. As I said, in the claims world, claims may not be paid right away. Claims may be denied. Claims may be denied for reasons that, changing the paperwork can't change. The date the service happened on was not part of the service authorization period. Nothing you can do about that. But if there's something else that you can do, we're going to take you through how to appeal an appeal for a denied claim. So next slide, please. So you can appeal a denial, but again, you want to know why it was denied. Some denials are not going to be changed. Some denials is possibility. You want to appeal for a reduction in the level of service payment. If they said, oh, we said we were going to pay you $10.73 and we're only going to pay you $8, that shouldn't happen. But if it does, and it's been happened in the past, you can appeal that as well. Or if somebody, you bill traditional Medicaid and it turns out they were Medicaid expansion, traditional Medicaid's going to deny the claim and say you need to bill Blue Cross and Blue Shield for that, et cetera. So that would also be an appealed claim in this case, and something that you can fix. You're going to bill the right, the right entity at this time. So next slide, please. Probably another 5 minutes on this because we want to give you guys your breakout on this. So next slide, please. Oh, within 30 days, you have to file the appeal within 30 days. So DHS or Blue Cross says, oh, we're denying this claim. They should tell you why. You need to file the appeal within 30 days of the notice of denial, or that also means that the claim you've accepted. If you don't, you've accepted that the claim is denied and you're not going to receive payment for it. You want 30, but if you're doing within 30 days, then there is the possibility that you can receive payment for it if the issue that caused the claim to be denied has been addressed. So next slide, please. So how to file an appeal. There is a state form for that. It's a written notice. You appeal with the Department of Human Services, includes a statement of the disputed item and the reason for the dispute. What could be different? What have you changed? You mail those appeals to the Department of Human Services. Next slide, please. Again, you'll have all these slides. You'll be able to reference all this material we pulled together. This is just a copy of the form, so you're familiar with that. This is for traditional Medicaid. Remember, if I have a traditional Medicaid person, I'm billing DHS for that. If they've denied a claim, I'm appealing to DHS for that. If I have a person who's Medicaid expansion, I am billing Blue Cross Blue Shield for that. They may deny a claim as well, and they will have their own processes, usually put out in great detail on their websites. but this is the form for the state appeal. DHS has to give you a decision within 75 days in regard to the appeal, and DHS's decision can be appealed. If DHS says, nope, we're still not paying this, then you have the ability to appeal that by the provider in district court. Excuse me, there's details on all of that here. The next slide, please. Just keep these 5. So we are now, oh good. So we're going to now go for a breakout room for the next 10 minutes. We're going to come back. It is 1:37 for you all. We're going to come back at 10 of and have you go back into your room. Same way last time, pick the agency that you're with. What do you need to put on your work plan in order to be able to submit a claim, have this information, and make all this work for your agency. So we're going to do about 10 minutes, make sure we have enough time here. All right. As always, we'd love to hear from you. What did you discuss in your breakout rooms? Have you decided on a billing system? How you decided how you're going to do this? What questions do you have? We've just got a couple more minutes before the end of the session. I'm sure somebody had some insights from the time.
Anyone start the process already? Anyone that's billed yet? Maybe you have some tips or just some encouragement or best practices to share for folks who are going to be the first ones to dip their toe in this water. Maybe we're all new and we're all doing this together for this particular services. So hopefully you guys will have an opportunity. I'm going to try to get these pushed out to you guys pretty fast today so you can go through all those steps that Marcella showed you or just explore it. So that way when we have our session tomorrow to ask the questions, maybe you can sit with the material for a moment so you feel ready to share or ask away and have that opportunity before we maybe all head out for a Labor Day weekend pretty soon.
Beautiful late August. Yep. So know that the billing guide we will share has not been adapted for anything other than housing supports. That's something that's on our to-do list for the fall, etc. But Ambrose will be sharing that with you, and it's also on the Grand Forks Housing Authority website. We're always happy to share that link if that would be helpful. A lot of the slides that you saw, the details for the MMIS system are all taken from that billing guide. So you can have the slide, you'll get the slide deck, and or you can use the, reference the billing guide there. So up next, as Ambrosia said, it's because it's a holiday weekend, we're going to do our Q&A session tomorrow from 3 to 4, so that's a little bit different. And then next Wednesday, we're going to talk about quality, ensuring that you're delivering quality services. So we need your program leads and we need your quality leads there. And that session will be our last session. And then September 9th, Ambrosia will end you up with a Q&A session. So if there are any questions or anything else we can do for you, please reach out and be in touch. For now, thanks and have a great afternoon.